Okay, very good. So a few housekeeping items just to kick off. I mean, we are virtual for the first time. And so we will ask all of you to stay muted unless you're speaking. We are being live streamed. All of us will behave accordingly. And we will, the other thing is, as we get into our sessions, we'll ask that you use the virtual hand raising on the Zoom to be able to be recognized to speak. So that's a little of our housekeeping. We're really excited about today's meeting. So to go over the agenda, we are focusing today on data, and we will be we're going to have comments when I finish here in a moment. We'll have some comments from Senator Kinley, Dr. Box, and Congresswoman Brooks, and then we will move into public input summary from Shane, and we'll have some of our commission members speak for a few minutes and give us their comments and thoughts, and then we will move into a data and integration presentation by Dr. Lindsay Weaver, our Chief Medical Officer, and then from there we'll have an opportunity to move into open discussion by the commission before we adjourn. And so a few things I wanted to comment on. First of all, the importance of this topic cannot be understated. Public health literally could not function without robust data collection, and that data collection needs to come from all levels. So when we talk about evidence-based solutions and policies, which we all are interested in, and that's very important, that evidence is formed from data and analysis that guides our approaches. This is a really important topic. And a few things coming up that I wanted to mention. Next week's going to be quite busy. So we have, on the national level, the CDC Foundation will be convening our second Lights, Camera, Action, the Future of Public Health Summit in our series on January 25th. Our topic next week will also be on creating an interoperable and modern data technology infrastructure. And I'm happy to report that Dr. Box and Dr. Lindsay Weaver will both be featured as speakers next week. So excited about that. On January 26th, Dr. Kane and Dr. Welsh will be having a meeting with all the local health officers from 5 to 7 p.m. So thank you for that. Quite excited. And then on January 27th, I will be joining, along with actually Dr. Weaver will also be a speaker at the Indiana Rural Health Association's public policy meeting, and they are celebrating their 25th year, I believe. So 25 years of celebration for the Indiana Rural Health Association. This will be a virtual meeting. Following my remarks, we will have a Q&A session and be able to hear comments from the participants. And I'm happy to report that Dr. Box will join me for that Q&A session next week as well. So Carol, thank you. Thank you for the invitation. So with that, I think those are all the announcements I wanted to make. So with that, I'd like to turn to my co-chair, Senator Kinley, for opening remarks.
Well, thank you, Dr. Monroe. And, we've continued to have our meetings with some interest groups, Dr. Box and I, and even though Dr. Box has been at home with the COVID, she has been a real Trojan and coughed her way through those meetings and done a terrific job. So you all need to thank her for what we've done there on that regard. Two things that I want to bring to your attention. First off, Dr. Monroe and I were invited to go to the Governor's State of the State message. And actually, we got a very prominent recognition of the importance of this whole commission and the ideas that we're pursuing in his speech. And for those of you that may not have listened, I really want to reiterate, he says, now as we strengthen Hoosier talent, we must also strengthen Hoosier health. While we've made progress in areas like reducing infant mortality, we have a lot of work ahead to be truly clicking. Here are the facts. Indiana ranks 46th in obesity, 46th in smoking, and 40th in childhood immunizations. And then he says, like everyone else in America, our efforts to tackle addiction in our community has been compounded by the pandemic. He mentions Lieutenant Governor's efforts to work with Hoosier mental health issues, making investments in mental health. We will also promote young Hoosier health and wellness by strengthening the guidelines for childhood lead screening and gathering more knowledge. And he says the task of improving Hoosier health couldn't be more important, and the time to do it never more pressing. And he says, and I quote, to realize new results, addressing these challenges will require new approaches. That's why the Indiana Public Health Commission will submit a report this summer with recommendations ready for the 23 budget session, so we can modernize and strengthen the state's public health system overall, one person at a time. And so he really emphasized the importance of our work and his commitment to the Public Health Commission. And I don't think we could have gotten a better endorsement. And then following the State of the State message, I met and I took David Reynolds and Jason Dudich, who've been a couple of our financial experts for the state of Indiana and are now in the private area. They're volunteering to help me. And we met with Earl Good, the chief of staff, and Chris Johnston, the director of the Office of Management and Budget. And I went through the progression of what it was we were doing. I gave him a report on all the visits that Dr. Box and I had done with these different interest groups. And then I kind of laid out in a summary fashion where I think we're going in terms of funding. I didn't want to surprise the governor's office or to have them, but they fully embraced what we were planning on and thought we were doing a good job, encouraged us to go ahead. I know in coming commissions, coming meetings, the commission is actually going to dig into the nitty gritty of which programs we want to fund up and in which order and how to do all this. But I think we're really getting a lot of support from the administration and recognition of the importance of the work that we're doing. So I was very pleased. I'm sure Dr. Monroe was too. And so I'm glad to share that with all of you. And I don't know if you noticed from other communication sources that you have, but it was really a resounding reinforcement of the importance of what we're doing. So turn it back over to you, Dr. Monroe. Thank you.
Yeah, thank you, Senator Kenley. And I agree with you. It was really a terrific message, and was very happy to be able to attend. Dr. Box, if we could turn to you for opening comments. We need to hear. Yeah.
You're muted.
Sorry, it's my first Zoom meeting. Anyway, good afternoon. Thanks everybody for adapting to this format. You know, we've had to adapt for the last couple of years, and with the Omicron surge the way it is right now, the commission has to be flexible too, and I appreciate that. In addition to today's meeting changes, we have postponed the 3 listening sessions that we had scheduled during the month of January, and 2 of those have already been rescheduled into March, and we're working on the 3rd one. I also want to look at, just how we use data at the State Department of Health and the health issues like COVID. We really have leaned heavily on the data to make day-to-day decisions, just like those that have impacted this commission. We've looked at case counts and positivity rates and hospital admission census and death rates and vaccine updates. All of that has been important as we've made the most difficult decisions throughout this pandemic. It's really important in how it informs public health across the state of Indiana, but it's really only the tip of the iceberg for the data that we use here as the state. Without data on immunizations in children with regards to whether they're protected from measles and mumps and other vaccine preventable diseases, and information from our hospitals on and health acquired infections and those infections that may be antibiotic resistant are all critical in the healthcare of our state. We also look at the rates of specific types of cancers across the state of Indiana. Is there clustering of that in particular areas? And if so, is there associated risk factors that we can find with that? We use data on substance use disorder and overdoses to determine where we need to work within communities to increase harm reduction strategies. And we know also to look in those areas for increased hepatitis C and HIV cases. So in essence, data really is the foundation on which public health is built. These data are not just numbers that are thrown on a dashboard. And I really want to emphasize the fact that all of this data is cross-referenced and verified against things like birth certificates and death certificates and hospital discharge summaries and admission summaries and lab data. And that's been really critical so that we can ensure that we are accurate in all the data that we give. We really do value data so much at the Indiana Department of Health that throughout this pandemic, we added a chief data officer and created a new division really that focuses solely on data collection and analysis across the state. We really are working daily with our partners to make sure that Indiana has the most comprehensive picture of public health issues from across the state. But like any other public health issue, data collection and use comes with its challenges. And so I'm really excited to hear from Dr. Weaver today, who has been leading our data charge throughout this entire pandemic and really been doing the deeper dive here in the state of Indiana. So thank you so much for joining everybody today.
Thank you, Dr. Box. And now Congresswoman Brooks, I'll turn to you.
Thank you, Dr. Monroe, and hello, everyone. Good to see everyone, albeit virtually. I just wanted to share what Dr. Monroe just talked about with respect to some national attention that the work of this commission is getting. I happen to serve on and I'm a co-chair of CSIS, which stands for the Center for Strategic International Studies. We've had an America's Health Security Commission that's been at work for several years. And on February 8th, Dr. Box and Dr. Monroe are going to be participating in a podcast with our leader of that group, Stephen Morrison. It's going to be on February 8th from 1 to 2. So I would encourage you to mark your calendars and to listen in, or you could get it online afterwards. But there is certainly national attention and interest in the work of this commission. And so I'm really pleased that Dr. Box and Dr. Monroe are going to be able to talk about it. I'm also really anxious to hear from Dr. Weaver now because of the critical importance of data, not only here at our state health department, but all of that rolls up as well to the federal government. And so much of the analysis of funding and so much of what we do comes from the data that the state submits to the federal government. And finally, as a citizen advisor, since I'm no longer a congresswoman, I just want to thank the State Department of Health. The dashboard is something that I started following right away, quite frankly. I had never followed a state dashboard on a very regular basis. And so I really appreciate that the dashboard has changed over times, that, it's pretty user friendly, that it is, chock full of all of the data. And so speaking as a citizen on this commission, people really do use and rely on the dashboard. And so I'm looking forward to hear from Dr. Weaver as to how other dashboards through the health department could be utilized, how we are utilizing them. I, quite frankly, have been very focused on the COVID dashboard and really haven't studied it otherwise. But thanks, and I'll turn it back over. Good to be here.
Yeah, thank you all for your comments. And I think when you talk about dashboards, that really speaks to the visualization of data and how important that is as part of the communication of what the information, what that all rolls up to. So now, if I could call for a motion to approve the minutes. Do we have a motion?
Motion to approve.
Dr. Welsh? Have a second? Dr. Halverson? Very good. All in favor?
Aye.
Aye.
Any opposed? Okay, so we have the minutes approved. Thank you. And now we'll move into our public input summary and remarks. And so I would like to call upon Shane to update us on our public comments that have been coming in.
Thank you, Dr. Monroe. As I sort through my desk here and find my notes. Over the last month or so, we have had approximately 160 public comments come in. Those come in mostly related to the COVID pandemic response, masking, as well as vaccines and mandates and other aspects of the response. It largely appeared to be a form generated response, and that was 158 comments in particular, all registering their opposition or displeasure with various aspects of that. We did have one respondent who was supportive of allowing businesses to require their employees to be vaccinated, as well as masking and mandating healthcare workers be vaccinated. We had a respondent from the Indiana Environmental Health Association concerned with food safety and prevention of foodborne illness, encouraging the commission to recommend restoring budget and staffing for food protection, as well as training to prevent foodborne illness. Another respondent spoke specifically about adding an actuary to assist with data collection and analysis in the Department of Health. And then finally, one respondent advocated for increased funding for public health in general. A copy of these specific comments have been provided to you in terms of the write-up, and we will also be happy to provide any additional detail if you have any questions, but that is what we have.
Very good. Thank you, Shane. Are there any quick questions for Shane? Any comments or questions? Very good. So we will. So Mindy Waldron, can I turn to you now? You have the floor for comments.
Sure. Thank you, Dr. Monroe and Shane, for asking me to make these comments. And because most know that I could probably talk about public health for hours, I did sort of note some of the things I wanted to talk about so I could stick within the timeline. So bear with me. I've worked in health departments and local health departments my entire career, spanning 31 years. And this included a very small health department, a mid-sized one, and a large one. So I've seen firsthand a lot of the things we've been talking about over these past months about disparities based on county population, local tax allocation amounts allowed, and the level of support received by various state and local officials per county. So, and I know I'm known for being very vocal about change and gaps, but it's really because I am committed to the best public health system for Indiana and why I'm so happy to participate in this group. So my comments here are not meant to place fault on anyone, especially not anyone here. They are comments just about day-to-day issues experienced by us as local public health folks. And I know that I share the hope of my colleagues that are likely listening in today that we have for betterment. So speaking about pre-COVID times, the public health system in Indiana has always been a bit strained, and it has worsened in some aspects over time through severe funding cuts, tax caps that have limited a lot of the local allocations, and sometimes an ever-changing cadre of state program officials who develop the rules that we enforce, and sometimes without our input, although we have a wealth of experience. And so I advocate that we need to practice the true meaning of teamwork as a public health system with an emphasis on valued two-way communication. And some of the current state leaders have embraced this, and we're very grateful for seeing some of those changes now. So just like we at the local level don't fully understand all of the issues experienced at the state level, those of us that do the boots on the ground stuff every day and work with our community hope that we can be part of decisions about what public health priorities deserve attention, and most importantly, how to address those with rules or grant requirements that are doable and not sometimes busy work. Otherwise, we're ineffective as the whole. So while Indiana's public health providers, state and local, are very passionate and well-meaning people, it only gets us so far, as we need a core structure that works equally for all levels of those who deliver these services. Each of the core needs for good delivery of public health service are severely strained right now: communication, adequate staffing, funding, training, comprehensive support for all things related to effective enforcement done consistently, data collection, which I'm excited to hear about today, and data sharing. And this is not just due to the impacts of daily and nonstop COVID work. It's been this way for some time. COVID is just the straw that's nearly broken so many of us who once had an unending amount of passion for the public we serve. But on a positive side, if COVID can be that catalyst that highlights how badly change is needed in the state to be effective, then we'll roll with that. As we look to the future of public health, we do have a long road ahead with the ultimate decision makers. Local public health departments have been vilified, threatened, stripped of some of our most important powers and tools, and our reputations have been tainted by polarizing issues, placing blame on us as individuals. Speaking personally, COVID-related issues and actions we've been required to employ have likely forever changed how some of my elected officials view me, as well as public health overall. So these things have become the current face of public health, and we need to figure out how we convince those in power that these changes that we're all discussing here can truly end up bolstering the community economic value or economic development levels that state and local officials so strongly value. These are folks who 100% control things at the local level. Staffing additions, new buildings, local rule changes, increased financial streams, and these can only flow our way if they feel we contribute to the community in a positive way. And right now, I'm unsure they believe that. And that makes me sad. These are our careers. And it's mainly because we're considered the enforcers of topics they and their constituents don't like, or issues for which they see little to no value. So we hope we can see change there and we can be part of that change. A lot of it's related to COVID, but certain other environmental issues. The value of public health, as we all know, is a really hard thing to sell, yet it's the backbone of the community's viability. So if we do our jobs well, it's hard for others to see when we don't, or see what it's like when we don't, or to recall when times, prior to life-saving vaccines for smallpox, polio, even COVID, before clean water, safe food, cleaner streets without sewage, and all the things that we do each day, including the gathering and utilization of good data. And every other public health intervention in the last century that has been attributed to leading to longer life expectancies. So to do these duties in a way that's meaningful and truly leads to safer, healthier outcomes, we need substantial support and change. Support, we're going to have to seek and foster, and we have to seek it out among some folks that may have currently written off public health as unimportant. And the change may be really painful for all levels because we all like our routines and how we've always done it, including me. However, seeing how things have rolled out over these last 2 years, it's clear that even though it might be tough, we all need to change our core infrastructure so we can provide equity and support. So things have got to get better. Somebody recently sent me this quote along with some really encouraging words about this commission's goals. The secret of change is to focus all of your energy not on fighting the old, but on building the new. So I'm really grateful to be part of this commission and to work alongside folks like you. And thanks for giving me a few moments to provide my input on the current system.
Thank you. Powerful words, Mindy. Thank you very much. So now we'll move to Carl Ellison for your remarks.
Good afternoon, everyone, and thank you, Dr. Monroe. I come at this more as a novice, although kind of an informed citizen novice. I spent 10 years many years ago, long before COVID, as a member of the San Joe County Board of Health. I did 10 years of service. And so I remember that each year when we come up to budget time, we'd spend a considerable period of time deciding, should we raise the fee and could we get the council commissioner to agree to that in order to be able to add a staff or to add a service. So we, my history and everything I've learned so far from the commission's work suggested we do indeed need more funding for local public health infrastructure, period. Now, exactly how we get the funding there and what criteria is done and how it relates to the impact on property tax and all that, I don't know. But I think fundamentally it's clear we do need more support. Now, we had a small group that met with Dr. Box and Senator Kenley, and one of our board members, Senator Jean Breaux, was part of that conversation. And what came out of that was a very strong support for local public health presence, keep the infrastructure locally there. But there was also some support for the notion of regionalization. We can find economies of scale. We can find some ways to share resources to make all local health departments more efficient, more effective, better able to use their time doing community surveillance and other things. That would be very, very helpful. And there were other comments that were made, but let me just shift gears a moment. And when I'm on a commission like this, I often say to myself, if Bill Crawford were here, what would Bill say? And one of the things that Bill did say was that health is the most essential quality of life issue. And that notion is what has driven the creation of IMHC and driven our work over the past 25 years. But Bill also would be very aspirational. And I think in the commission's report, I would recommend that we look at a longer term context. We do healthy people goals over 10-year spans. Given as large as this elephant is, no matter what we as the legislature do from a funding perspective, that's an initial investment. It's not the end of improving public health in the state. So, so my view is that we might want to be aspirational and just as a context, say, do we want to be at 50% of the state health rankings by 2033? Or do we want to be at some other percent? But we need to set some aspirational goal that would drive effort over the next 10 years to get there. And look at what do we recommend to the legislature as sort of the first investment, just the first start of a longer journey. So I encourage the commission to articulate this as a long-term initiative that will take time, it'll take collaboration, it'll take mutual understanding, but it is something that can be achieved pursuant to what we set our goal to be. Now, bear in mind, part of what led me to this beyond Bill Crawford is that the governor, with respect to infant mortality, stated that we wanted to be the best in the Midwest by 2024. So having some kind of clear goal, I just think is very, very helpful to whatever we might recommend. Now, insofar as race ethnic populations are concerned, part of what came out in our discussion was that we would need more emphasis on obesity, on diabetes prevention and other preventative services. Infant mortality continues to be a concern, smoking, and then probably in all the years I've done this work, since we're talking data today, the improvement of race ethnic data collection, data consistency, and the ability to really be able to measure for race ethnic populations how we're improving or not improving. So race ethnic data collection is not just an issue in Indiana, it's obviously a national issue, but we do need to see some significant improvement there to help population of color and others just be better able to articulate and understand, are we getting better, are we getting worse, how are we improving from year to year? I think this is a large issue for the public to understand. And I don't know that we can message this in a short-term way that will make sense to people. But I do think that if we study it as a sort of a 10-year campaign and take whatever recommendations are, not just to the legislature, but also to communities, we stand a chance of getting better consensus around what the priority investments ought to be, as well as what outcomes we expect to achieve through our work.
Thank you very much. And now we're going to move to Brian Taylor for his comments.
Thank you, Dr. Moreau. Well, I will just start off by saying that Carl is someone that I've looked up to and sought his advice in this area. So if he's calling himself a novice, I don't know what that makes me. That's something lower than rookie. But I just want to thank the rest of the commissioners because I have also learned so much throughout this process. Mindy, that was very, very powerful. I appreciate your comments. Senator Kenley mentioned one thing I wanted to state up front, which is for my fellow commissioners and then also for anyone following the proceedings. I don't think we can ignore, or we should definitely be thankful for the emphasis that the governor put on this commission and its work in the state of the state. So I'm glad that Senator Kenley noted that, and I'm bringing it up again because it's very significant, and it may not have made it into quite the number of articles that I would hope. The media tends to focus on some of the more immediate things. It really, I think, just is a challenge to us all. So there's a lot riding on this. Clearly, he is very invested in this, as is the entire administration. So it means we all have to bring our A game to this effort. Something Carl said also blends nicely with what I wanted to mention, which is kind of a bit of optimism, but it ties in with the aspirational goal setting. I wanted to go back to something that I noted at the outset of this process, and it was my colleague Ben Harvey with IFCA, who actually reminded me not too long ago that if you go back and look at the history of Indiana's health rankings, we used to be much closer to middle of the pack. And in the report that Dr. Halverson did, I think going back to something like 1990, we were around 30 or so, which is not great, but it's been sort of a slow slide since then. So, but nevertheless, we have not always been where we are today. And I think that provides us, should provide us with a sense of optimism that we can do better and that we can set an aspirational goal and target that. Now, how long it's going to take us to get there, I don't know, but I don't think there isn't any reason why we can't aspire to be at least average by some point in time. And so I think we should consider that as well. Echo Carl's sentiments there. One of the things I think is going to be a challenge, but a challenge that we can meet through this process, is going to be challenging or engaging with some of the constituents and outside of public health and healthcare generally. So I think as we go forth and engage, I know many of us are talking to others, and that's been something we've been asked to do. And we've certainly been doing that, try to find other partners to make them aware of this effort and bring them on board and create buy-in. There was a quote that I came across, let's see if I can find it, here it is. And it was a quote from Dr. Benjamin, the president of the American Public Health Association. I'm not sure if that's current, but it was the quote, "It's a four-legged stool, state, local, and federal public health and private sector partners who should see public health as part of what they do." I think that fourth part is going to be a little tougher. I think everyone in this group is all in. We're going to have to think about ways that we talk with the business community and others who aren't traditionally engaged in public health to understand why it matters to Indiana, why it matters in terms of increased worker productivity, increased quality of life, making Indiana a more attractive place to live and do business, all of those things. So I think we need to spend some time thinking about how we make those, how we sell those who aren't, living and thinking about public health all the time. I think we should have a session where we work on that. I did just want to echo comments I made earlier on in the process that I do absolutely think we need to think about regionalization. Public health doesn't stop at the county line. Thinking about how we create a basic level of public health support for every Hoosier, no matter where he or she lives. I think that is absolutely a goal that we need to strive for. And lastly, workforce. Appreciate very much that in the General Assembly this year, House Bill 1003, something that we're calling Nursing Indiana Back to Health, is legislation is moving forward. Representative Ethan Manning is carrying that. And I think it's a significant step in addressing at least the nursing shortage that we had before COVID, and that now has been worsened to just an untenable degree. I had a nurse leader recently tell me that it will take about 5 years, and this was from a study. One study indicated it'll take about 5 years to get us back to 75% of the workforce in healthcare that we had before the pandemic. And I think that's probably optimistic. I know that report came out before really the sort of Delta Cron wave, where we had these two waves that we had at the end of the year and that we're still experiencing. So I think it's probably a much harder climb than that. And as we talked about recently in one of our meetings, we're not going to be able to meet the needs of Hoosiers without that public health workforce. So I think as we think ahead to that session, tying in the work of the commission, whether it is the reorganization, looking at regionalization and so forth, the funding for the state, I think we absolutely need more resources there for epidemiologists and others. But I think we're going to have to stay closely aligned with efforts to expand the healthcare workforce pipeline and either make that part of our mission or make it really a joint effort, because we're not going to be able to meet those needs. The workforce is just extremely depleted at this point. So just some observations and thoughts, and thanks for the opportunity to share them.
Yeah, thank you, Brian. Thanks to all three of you. Those were all very complimentary remarks, and I think spot on so many of the points you all made. So now we're going to turn to Dr. Lindsay Weaver and give her the floor. And what I would ask is reserve your questions. We'll let Dr. Weaver get through all of her presentation, especially in this virtual environment. And then we'll have plenty of time at the end to cover questions and have discussion. And so, Dr. Weaver, over to you.
Thank you very much, Dr. Monroe, and everybody. I really appreciate your comments. You have teed me up for this presentation, recognizing the importance of data in all the work that we do every day. I am going to take myself off camera because I have 3 screens I'm navigating, so you don't have to watch me look around here. But hold on a second. Whoever is the host, if you can enable me to share screen, please. Or if the host could share the slides. Saying I'm disabled for screen sharing right now.
Shane, do you have this?
Looking into it.
Thank you.
Let's see if there's anything I can do here.
It is our virtual world.
It is. It is. And this is not my first Zoom meeting either. All right. Okay, Shane, let me know if you're able to allow me to, I think I see it now. Hold on.
You should have access now.
I do. Thank you. There we go. Is it working?
Yes, Lindsay.
Wonderful. Thank you.
Looks
So
good.
good afternoon, everybody. Again, my name is Lindsay Weaver. I am the Chief Medical Officer here at the Department of Health. And I have been here since February of 2020 and have been all in assisting Dr. Box and the Department of Health with the COVID response since that time. So I am, this is my disclaimer. I am an emergency medicine physician by training with actually no official training in data, technology, or analytics. So why am I talking to you about data collection and utilization in Indiana? Well, for the last 2 years, I have witnessed firsthand as a public health leader, a physician, and a citizen, how data can shape and inform how we prepare, react, and treat a public health threat. The 4 core values of the Department of Health are founded in data. We can only ensure every Hoosier has access to the same care no matter where they work, live, and play by monitoring health outcomes data. We use data to innovate evidence-based practices, and data has helped us communicate the benefits of vaccines and other components of the COVID response. And we have maintained integrity by being meticulously transparent with our data throughout the response. I will talk a lot about COVID today, only because I do feel that it has shown the public and leaders, both in the state and nationwide, the importance of data and how it best can be utilized in what we do for the future of public health. It really has been the catalyst to the future. The pandemic has not only highlighted how data can be used to inform policy, guide interventions, and be used for public communication, the pandemic has also pushed the receipt and analysis of data to limits never before seen or required by public health. So for example, this is a screenshot of the original COVID-19 dashboard from the spring of 2020. The data displayed here required a significant amount of manual data input and calculations. Fast forward to now, to today, when we have been told by both federal and national state leadership that Indiana has one of the most robust and interactive dashboards in the country. Thankfully, we had a good backbone of connectivity prior to the pandemic on which to build. This data has been utilized by businesses, speaking of which, universities, K-12 schools, local and state leaders, the entertainment industry, hospitals, clinicians, and individuals. There have been 5 million views of this dashboard in just the past 90 days, a quarter of all the Indiana.gov webpage views, and peak views are at 120,000 per day. Data clearly matters to the public. So all of this did require a lot of work. It didn't happen overnight, but it did happen really quickly. So every box and arrow on this screen represents the data sources and sharing that is needed to inform our dashboard and our stakeholders over the last 2 years. The yellow boxes here represent new data sources and connections, and the blue represents those that were enhanced during the pandemic. Where other states were needing to hire hundreds of employees to input data, because of our good foundation and excellent partnerships, we were not only able to electronically receive lab information on cases from labs and hospitals, but we were also able to quickly make that bi-directional so clinicians could see their patients' test results. We are at a unique point in history due to the COVID-19 pandemic that has provided us with incredible access to resources and has created the momentum necessary to position our agency for the growth and transformation necessary to prepare for the next health crisis impacting Hoosiers. We need to be able to pivot from this great work we have done in leveraging data and responding to the pandemic to create a culture and an ecosystem that uses data to engage individuals, deliver high quality care, and improve population health by making data information accessible when and where it matters most. The time is now to assess, optimize, and create a sustainable environment that allows our teams to reach their full potential. The journey is the evolution of our agency into the digital age. When most people think about healthcare data, they think about their own information and their own health record interactions with their clinicians and providers. There have been an effort in the last 2 decades to move clinicians to paperless systems and to connect those systems through health information exchanges, and Indiana has led the way. A clinician's access to robust patient health information at the time of care does inform and affect not only the patient care, but public health. So most people assume when they visit me, for example, in the emergency department, that I'm able to see all of their up-to-date information, like what tests were performed at their long-term care facility, or what new medication their cardiologist put them on. However, despite the significant advances in our health connectivity, there remains gaps in information, including that important long-term care information and the new medication that the cardiologist has placed their patient on. So the data collected into these systems forms the backbone of public health. So we can utilize that data that is going into those electronic medical records and going into that health information exchange for local disease surveillance that could lead to outbreak identification, which then would lead to communication to that community and treatment. The data can also alert us to areas, for example, with higher infant mortality, or maybe we see a increase in a certain area of high child lead levels that can inform programming and funding for that area. So our goal is to utilize data sources for predictive analytics so that a signal in this health data can lead to outbreak identification for diseases like syphilis and HIV that alerts officials about acute crises earlier rather than later. The needed data goes beyond strictly clinical. It allows us to assure that no matter where someone lives, they are receiving the needed resources and access to care. Public health data is an entire ecosystem of stakeholders, clinicians, state and local leaders, public health, and research. Our leading public health schools, including Fairbanks and research organizations such as Regenstrief, have been an integral part of public health in the past and will be in the future. So we must develop a shared vision of this public health ecosystem for a coordinated exchange of actionable data between healthcare data and public health agencies. The problem is that historically, public health data has been siloed by disease conditions, federal funding sources, and reporting requirements. It is also limited by outdated data sharing laws. So systemically, the Department of Health consists of 100+ applications, 50% of which that include crucial public health data and no centralized data environment. This is not just here in Indiana, but it also exists with our national partners with whom we are required to submit data for example, funding resources. There is a lot of duplication of effort at every single level, whether that be locally, at our local health departments, in our hospitals, at our labs, in the state, and also nationally. Thankfully, there is a national movement towards data modernization and improving connectivity and the deduplication of all this effort. So for example, the CDC has developed a data modernization initiative strategic plan. Simultaneously, we have begun our own efforts here in Indiana that I will go into detail later. So how does this effort affect the individual citizen? An example is that currently EMS data is not seamlessly connected to the electronic medical record or the health information exchange. So for me as a clinician taking care of a patient in the emergency department, I just have to hope that the the EMS crew left the paperwork somewhere that I can find it. So I know what medications were done, how the patient presented, and their care that was given during that time. As a public health leader, I am unable to fully appreciate if the EMS trauma care provided in a rural community equates to trauma care in our big urban areas. So how do we address those gaps? So as I've mentioned, there's something called health information exchanges. So a health information exchange allows clinicians to appropriately access and securely share a patient's vital medical information electronically, improving the speed, quality, and the cost of patient care by avoiding medication errors, avoiding readmissions, and decreasing duplicating testing. So for example, again, if you came to visit me and you already had an x-ray in your clinic, if I'm able to see that x-ray and the read for that x-ray, I don't have to repeat it in the emergency department. There are health information exchanges in every state in the US, but all are set up differently. In 2009, as part of the American Recovery and Reinvestment Act, the Health Information Technology for Economic and Clinical Health Act was signed into law that promoted the adoption and meaningful use of health information technology. So it was through that funding that some states developed their own state-operated health information exchanges, otherwise known as HIEs or HIEs. Others had developed public-private partnerships, and others were formed privately, as in the case of Indiana. And those were developed independently. And here in Indiana, they were actually started development before this whole process began. So we're set up in that way. They are funded by different mechanisms. So just for example, health systems and payer-funded taxes, grants, transactional funding, subscription services, and participant fees, which is what's done here in Indiana. They can receive federal Medicaid match dollars and then also funded through the state general fund. They also provide an array of services like the clinical portal, where a clinician can go in and look up their patient's information, a master patient index, also opportunities to receive alerts. For example, if you are a primary care provider, to be alerted that your patient was admitted to the hospital, secure messaging, image sharing, so on and so forth. So a lot of opportunity with these health information exchanges. So in Indiana, we have now one health information exchange. We are down from 5 originally. We had recently been to 2 and now have 1, which is really good and significantly improves our connectivity here in Indiana. To, our patients don't stick inside their border, they don't stick inside their district. So the ability to, if someone comes from Lake County down to Indianapolis for care, to be able to see that information and what care that they have been receiving is very helpful, both again for the clinical perspective and also from the public health perspective as we watch and monitor patients move across the state. So the Indiana Health Information Exchange is the oldest HIE in the US and is one of the nation's largest clinical data repositories. They have participation of more than 120 hospitals, 18,000 practices, and 15,000 providers. And nationally, Indiana hospitals are the most likely to be able to exchange public health data electronically. Just as a reminder, we here in Indiana do not have a state designated health information exchange. This is done in other states. There's no state funding directly for the HIE. No Medicaid matching dollars are applied, and HIE is funded by its participants, so namely the hospitals. There does remain an opportunity for further development and partnership with the HIE to enhance it both for the clinical level and also for public health. And of course, those enhancements do require funding. So this map does show you an overview of the different HIEs across the country. So for those that do get Medicaid funding, they receive a 50 to 90% matching federal funds. Options for the state Medicaid matching dollars, for example, are first from state general funds. An insurer assessment is what's done in Kentucky. And hospital assessment, as an example, is what's done in Maryland. We did reach out to several of the health information exchanges that are surrounding us, as well as research how they are used for public health across the country. So in speaking to Kentucky, we did find out that they operated their 22 budget of $24 million. All data is free to their participants, and they get Medicaid funding with 75% federal dollars of that. And they do fund an incentive program to get providers to connect to their health information exchange. Of note, and I think it's really important, and this really is the future of why, another reason why this is so important, they did implement an image sharing option expected to generate $17 million in savings from avoided duplication of like x-rays and CT scans over 2 years. So Michigan is a state, has a state designated health exchange, and they use it to watch for pay for performance. Vermont State IT Fund is supported by health claims tax to support the state designated health information exchange. Ohio does not have a state designated HIE. They actually have several across the state. And just as an example, the one that is in the tri-state area, the Health Collaborative, also serves as its regional disaster response. So there's lots of different models out there. I'd be remiss, of course, to not talk about the role that that our local health departments play in data. So an important component of public health, of course, relies on the amazing work of our local health departments. It will not surprise you to learn that, similar to other discussions you guys have had with the governor's Public Health Commission, that there are significant disparities between our 94 local health departments, also with their access to data and their ability to analyze it. So local health departments are responsible for local public health data reporting. That data reporting is county specific, which sometimes may miss a regional impact. Again, when you're looking for and monitoring outbreaks, if you're looking at obesity or diabetes for a region, that regional information is definitely more helpful sometimes than that smaller local health department, what they're able to receive. Local health departments often do not have the ability to analyze data or provide local dashboards to support health action and policy. And we found that many local health departments at the outset of the pandemic actually didn't even have the technology to receive a Microsoft Excel file. So we could not even send them reports on their case data information because they were not able to pull it up due to not having access to Excel. And we also found through outreach and surveying that there were concerns for cybersecurity with some of our local health departments that have since been addressed. We only, so in December of 2021, so just this past month, we did survey all of our local health departments, specifically asking around about data, and 54% of them responding said that they needed additional data access, with 44% of those saying they need access to 3 or more resources. Only 2 of our local health departments are connected to our Indiana Health Information Exchange. St. Joe County and Marion County are the 2 that are connected. In addition to that access, Marion County also gets a feed of reportable lab conditions from IHI for residents of Marion County, and they also are able to contribute back in to the Health Information Exchange and database. Marion County also is able to utilize a application, it's called Docs for Docs, where they can send out messages to physicians that work in Marion County to alert them of outbreaks such as gonorrhea or influenza or hepatitis C, and give them the clinical information they need to address those outbreaks on the front line. So of note, IHI does hope to connect more local health departments over the next year, and I think there's definitely an opportunity to expand that Docs for Docs application across the state so that we can be able to communicate directly with clinicians in different areas and notify them of outbreaks and the appropriate clinical approach. So in that same survey, we found that 77% of responding local health departments reported needing assistance performing analysis. A smaller, but definitely not our smallest health department, did share a story with me that in the beginning of the pandemic, his food service administrator was calculating the COVID numbers on a calculator in order for them to update their dashboard. So the level of differences between us here at the state level, where we have an entire team of data analysts, we have epidemiologists to review this, and the difference between the different local health departments is quite profound. And people want to hear from their county. They want to hear from their community, people who are living there and know that and know them and that information. So they are going to those local health department websites to review further. So unfortunately, we've seen this a lot with workforce issues, that there is also a workforce with data analysts, especially health data analysts. There is not enough for every single local health department to have somebody to help support the work that they do. So this is another opportunity, really, where sharing a data analyst between several different counties could be beneficial. And I will say, time and time again throughout the pandemic, and also, again, it's not just about COVID, it is all of the things that we do, whether it be cancer, obesity, diabetes, trauma care, sepsis, all of those things. It's really that regional look that our patients move beyond borders. They may go to the hospital in the next county. Maybe their birthing hospital is actually 2 counties away. So those regional looks are an important aspect as we develop our plan for the future. When you compare Indiana local health departments to national on the national landscape, you can see that we actually do really well in 2 areas: our connection to our immunization registries and also connection to electronic disease reporting systems. But you can also see that we fall significantly behind with access to electronic health records, electronic lab reporting, and an access to the health information exchange. So just to dive into what we are currently doing, as Dr. Box talked about, we have recognized through COVID and in general that we have a tremendous opportunity here to set us up differently and for better in the future. The Indiana Department of Health goal is to develop a secure, connected, resilient, sustainable, response-ready public health data environments so that we can be more reactive to public health with our predictive analytics, so we can identify a problem before it is a full-fledged outbreak or issue. And by collecting real-time data and then analyzing it to inform actionable next steps that are based in evidence. We are doing this through, as Dr. Box mentioned, we now have a chief data officer that was hired and established, and also established the Office of Data Analytics. Through that process, we're now working through a level of discovery. What applications do we have? Where are we duplicating efforts? Where do we need to improve our security? And then really starting to develop that roadmap of what does data and technology look not only for the Department of Health, but for public health for the entire state. And we can't do that without our stakeholders. So through this process, we have also formed an external advisory committee to help provide public health recommendations. So these are stakeholders from all sorts of different aspects of public health. We have local health department representation, Indiana State Medical Association, the Indiana Hospital Association, Indiana Healthcare Association. We have hospital leaders. We have the HealthLink FQHCs, we have pharmacists, we have the Fairbanks School of Public Health, we have Regan Street. I can't list them all, BioCrossroads. I mean, really all the important players that are part of public health at the table to help give input onto what does this roadmap for public health look like for the future. Some of the things that we talked about, I've already mentioned before, is enhancement of our health information exchange. And IHI is at the table as well. So our Indiana Health Information Exchange leaders are at the table as well. We heard from them that they want to expand the IHI infrastructure. We have a great base there. We need to have all of our general practitioners on, outpatient clinicians and specialists. We need to get our long-term care facilities onboarded as well, critical access hospitals, behavioral health clinicians, and it was also mentioned, better access to people's prescriptions. Every clinician should be able to have rapid access to basic essential information, and then we need to be able to use this metadata that is being collected to be in line with the state's goal. So if our goal is infant mortality, we can utilize the data that is going into this system to help direct better care. Look at a woman's blood pressures prior to and after delivery. We can look and see, at the extent of prenatal care that is being provided in the outpatient setting, and really utilize all of this to further develop programming. They also gave input on how what that looks like. Just to note and comment that they see where there is a need here. They noted that the lack of data right now, they feel is contributing to the STD crisis in Indiana, and the lack of an adequate response to curbing that epidemic. They say they have no ability as a system, so like across several counties, to analyze lab results outside of a specific hospital or a specific county. And so really collating the data, and they have said that they would like to see the Department of Health lead that information. As I mentioned before, we are not alone. There is definitely a national trend toward data modernization. For example, the American Rescue Plan included $80 million to strengthen the public health IT. And I had also mentioned before that the CDC is investing in data modernization with their initiative and investment of $1 billion, with the move from siloed and brittle public health data systems to connected, resilient, adaptable, sustainable, response-ready systems that can help us solve problems before they happen and reduce harm. So to summarize, next steps and recommendations for public health data, we need to be able to continue on the Indiana Department of Health digital transformation and development of a statewide data and technology roadmap for public health for the state of Indiana. A recommendation to formalize our partnership and invest into the Indiana Health Information Exchange to enhance its capabilities and increase its connections to these other clinicians and providers, like I mentioned, long-term care facilities, EMS, and have a way to better utilize that data to inform public health care. Formalize partnerships with state public health schools and research organizations, and we have to invest in our local health departments' data access, utilization, and also the data workforce. So thanks to all of the following people have participated in these data activities. It has been an eye-opening experience for me, and I am happy to answer any questions.
Wonderful. Well, thank you. That was a very robust presentation. A lot to unpack there, a lot to be proud of in Indiana. So congratulations on the successes, and also heard a lot of opportunity for going into the future. So Dr. Welsh, you've got your first virtual hand up with a question.
Thank you. So a couple of questions, and then I'll stop and listen. I have a question as we move forward. Are we making sure that we have contingencies to correct information that's found to be inaccurate? That can be sometimes a problem in some hospital systems where it gets entered that someone's allergic, say, to latex, but they're not really. Somebody entered it incorrectly. And if we open up across the state or across the region, how we can correct that. The other thing has to do with, as we're collecting data, if we have contingency to deal with adjacent states. So Northwest Indiana, a lot of people can go to Chicago for their health needs. Southeast Indiana, they go to Cincinnati. They can go to Louisville. So I can tell you a firsthand public health issue years ago where we had a lot of kids and from the small town in Southeast Indiana getting cancer. They were being treated in Cincinnati. That information was going to Columbus, not to Indianapolis. So it was not addressed in a timely fashion as it could have been, because that information was not getting to Indianapolis. I can tell you where I'm sitting in Southeast Indiana. I have been exposed to both the health information exchanges in Indianapolis and Cincinnati, and they're extremely helpful. But one other area of all the stakeholders, as you're discussing, I might suggest is IDEM. And I'm thinking specifically, we have good studies now showing that you can do analysis at sewage treatment plants and find problems arising in a community prior to them hitting the local hospitals. Just some thoughts. Thank you.
Thank you. I really appreciate your comments, and I agree with you. As part of this community of stakeholders and working with all the real data gurus fully agree that there has to be systems in place to make sure that we are monitoring the data that you receive is only, or that you put out is only as good as the data you get in, right? So we have to monitor for corrections and establish data governance. That's a huge part of all of this, is the data governance. I thank you for bringing up sharing with adjacent states. That is definitely a goal from at the national level. And I will say, you know, personally, I also agree it is very important. It has impacted us here in Indiana. As we saw our patients, you know, get their first vaccine in Florida and then have to try and come back up here to get their second, or vice versa. We've seen it also across the river. You know, patients may live in Indiana, but they actually work in Kentucky, or their hospital that they're referred to is in another state. So I think all the states have recognized that we need to have better data sharing across borders. The health information exchange that you work with down there in the greater tri-state area, it does cross all the borders. So, I mean, there is precedent for that, and it is very important, and that's recognized on a national level as well. We have utilized wastewater even in looking for COVID, and there's definitely possibilities to extend that in the future for other diseases.
And for the others on the commission, Indiana has had good work with surrounding states with our Inspect program. And I know Dr. Weaver, as emergency physician, knows this. I'm in Southeast Indiana. Being able to go on Inspect and get information about patient from Ohio and Kentucky is extremely helpful. So we already have some precedent in the state, and I applaud our state for what they've done with Inspect. And Inspect also will push out important information to physicians. If I'm prescribing for a patient and they're noticing that they're also getting prescriptions from multiple other physicians, they will alert me and the other physicians so that we can make appropriate action. Just so the commission knows. Thank you.
Thank you. Dr. Halverson, did you have your hand up, virtual hand? Or did you take it back down?
Yes, I did. Thank you, Dr. Monroe. Dr. Weaver, I just wanted to say thanks. I think this was a great overview presentation and a lot of great work that's going on in our state, and I really appreciate it. I wanted to compliment one of the comments that was done on the image repository, and as we all know, the leading cause of death for all people between 1 and 44 is trauma. And, you know, one of the great things that these when I was the health commissioner in Arkansas, we actually established a image repository sharing system over 10 years ago. And it has been an enormous time saver as well as a money saver, because it has actually reduced the ability of the time necessary to not have to repeat studies, particularly in the case of severely injured patients with CT scans and MRIs and so forth, and the multitude of different incompatibilities between and among hospitals. And I know Dr. Welsh and I share a strong interest in our trauma system, but that's just one example of how you know, our information systems can really support in real time the patient care needs, and that's a technology. It's easy to do. It's very cost effective, and it would be a great part of whatever we do. And I would heartily suggest we look at it. But I also wanted to talk a little bit about local public health resources in particular. I think it's really important, and we absolutely have got to focus on the interoperability and the robust clinical information exchange for all the good reasons. But I also think we ought to make sure that we don't lose track of the day-to-day, what I call bread and butter public health. And these are the systems that, frankly, are yet to be built, that need to help create the modern tools that we need. And I'm talking specifically about programs for environmental health programs that actually serve the needs of day-to-day public health, of people that inspect and create reports on septic systems and all of the environmental health, soil conditions and so forth. You would be surprised to see that in almost, in most cases, certainly here in Indiana, but this is true across the country, much of environmental health is still paper and pencil driven. And also just our day-to-day work in restaurant inspections. Why is this important? Well, first of all, automation can help make us more efficient. And then secondly, because almost all of these environmental health issues are paper and pencil, they're not in a database, and we can't quickly identify trends. And so from a public health perspective, this is a huge opportunity to bring value to our local health departments and to gain insight into potential opportunities to spot trends and concerns, and linking it with GIS data and so forth. I think has enormous opportunities for improvement. The other point that you made so well, and I want to just emphasize it, is that frankly, again, coming back to Indiana and our lack of trained and adequate staff, and by adequate, I mean, we just don't have enough people, and they frequently don't have the skills necessary, so that even if tomorrow we were to install the best information system in the world, we don't have the people that are trained and able to have the time and have the expertise to actually do something with the data. And to me, that is one of the most significant issues that we have. And it's interesting to me from a policy perspective how often we're willing to spend money to buy a computer system, millions, billions of dollars, but we forget about the importance of having the trained people who are actually able to then receive the data and, more importantly, take appropriate action based upon that data. So the workforce issues are substantial, the training and the adequacy in terms of numbers. And then just lastly, let me just suggest that, again, as a counterpoise to the clinical data, again, not saying we don't need it, we certainly do. And I, in particular, would emphasize the great value in having a state sort of data utility. And again, I've had a lot of experience in a couple of states looking at that kind of a model and being able to use Medicaid funding to help support the data exchange efforts. But one of the things in public health that we look at a lot is more related to things like the county health rankings and the large databases that are necessary to look at patterns. And these are not clinical data sets necessarily, but they have to do with things like poverty and the location of places that don't have access to running water or septic tanks. And, there's a whole host of issues that are data oriented that aren't about clinical data that tell us a lot from a public health and population perspective, which we need to have access to and be able to bring things together. And that's the very, very last point, which is that as we look at public health informatics, we see a growing increase in the whole idea around artificial intelligence and smart systems, where it's not just about looking at one data point, but it's looking at hundreds of thousands of data points and then making some sense and looking at trends. And I know that that's ultimately where we need to go, but it all depends on having these good foundational data systems in place. And so from hiring your own health data officer and all of the things that you're doing, it's just terrific. And I just wanted to put an exclamation point on the importance from a public health perspective. There are so many people that would say at the heart of good public health is a good data system. So thanks for what you're doing. And just to emphasize a couple other things.
Yeah, thank you, Paul. Really good points. Okay, so we have 3 hands up. We're going to go to Dennis Dawes and then Susan Brooks and then Hannah Maxey in that order.
Okay, I am unmuted and I hope you can hear me. I'm in a large lobby of a building, so there may be people going back and forth behind me. I apologize. I can't control that. Couple of points. Or a question I guess I have. I am very familiar with IHIE, and when I was working at the hospital in Danville for years, early on, when IHIE was basically just begun, I became familiar with that. My question is, I guess, does it help if an organization like IHIE in Indiana is a designated HIE? Would it help if somehow Indiana designated that organization as the Indiana Health Information Exchange? That's the name of it. But would there be more money coming in? Would there be the ability to expand that and so forth if it was, quote, designated, whatever that means? I think it's a good organization. I think it can do a lot more than it's doing and perhaps expand more into the public health side of what we're talking about as opposed to the clinical side. So that's a comment and a question, and we may not know that answer. So I throw it out there. A comment I made several meetings ago, I think, when I made it, and it might have been kind of at the end of a meeting. So bear with me, and I apologize. But when I was a young kid, fresh out of college, my second job was to work for an organization that was called Indiana Health Careers. I don't think it exists anymore. I was hired by the Indiana State Department of Health, Division of Health Education, and I was sent to Indiana Health Careers, and I traveled the state and went into almost every high school across the state of Indiana, talking to basically then high school kids about health careers. Here is an opportunity, perhaps again at this time, to do something like that. And I don't know how it would be done, but I think there were 3 of us that traveled this state, and we were in high schools from Munster, Indiana, to Evansville, to New Albany, to Brownsburg, Richmond, so on. And we pushed it. And I think, and so that would have been, pardon me, 50 years ago. All right. So that's another comment and or thought that perhaps the state needs to look at something like that again to really push health careers and figure out a way to get more young people interested in health careers as a profession. Quite frankly, I talked myself into becoming a hospital administrator. So what did I have to do that? I had to get a master's degree and so on. And I knew exactly what I had to do to go about it because I learned all of that in telling high school kids, here's what you have to do. You want to be a hospital administrator, here's what you got to do. If you want to be a nurse, here's what you have to do. If you want to be a neurosurgeon, here's what you have to do, so on. So I'll throw that out and I'll be quiet. Thank you.
Thank you. That's a terrific story and a terrific example of what the future could hold. So Congresswoman Brooks, I think you're next.
Thanks. And thanks, Dr. Weaver. I do have a couple of questions. Can you share with us, first of all, if there are other states? I think it's always good for us to put out, especially for the legislators, what are the states that do this best? Which states do what you're describing the best? And I appreciate that you reached out to some of our neighboring states, but I'd like to know that and how long they've been at it. I guess I'm curious also why we're one of 9 states, if you know, that doesn't receive Medicaid funding for our health information exchange. If we were the first, and maybe our co-chair Luke Kenley knows this, but what happened and why have we never tried to seek Medicaid funding when we're one of 9 states not to get funding for our exchange? And then staying with the funding, the high-tech funding, which is a federal funding pot, are there restrictions and requirements, and why doesn't our state get that funding? You mentioned that for the exchange. And then finally, if our local health departments, and we know have significant workforce challenges, what kind of infrastructure do you think needs to be put in place for our local health departments to begin utilizing the data that the health exchange can provide? Do we need regional data people that are, the public health IT experts to provide those reports? Or, so those are my small questions. Thank you. Yield back.
Not small questions, I will tell you. So as far as other states, I can't say that there is like a 1 or even 2 states. There's lots of different states that are doing small things really well. And so on top of, just looking, reaching out to the states around us, we did do research. And there is a National Health Information Exchange organization. And I will say that IHI has been profoundly helpful and kind of talking through the possibilities here, right? I mean, definitely acknowledge that there's opportunity to expand. It's about prioritization, it's about funding. To go talk about the Medicaid match funding and high tech, honestly, at the same time. So high tech is actually over. It was started in 2009, ended, I want to say it was, and somebody else probably knows better than me, but about a year ago. The thing with the Medicaid matching funding that has been explained to me is that they were looking to have, how can this become a sustainable model, right? And how is it going to improve the Medicaid care? They are actively looking right now because we do see this future in investment and have been told, there is a goal to make this sustainable, these health information exchanges throughout the course of time, and recognizing that funding is a part of that. So they are actively looking at it right now. How to engage and where Medicaid match funding can apply. Because of course you have to keep in mind, they have to be Medicaid providers. How does it affect the Medicaid population? And so what is the right implementation? One of the things that they're considering is getting, using that funding to help get long-term cares connected to the health information exchange. And then local health departments, 100%, I think having regional support would be profoundly helpful. We have supplied county level reports to our local counties, like on a weekly basis, for example, looking at race, ethnicity, social determinants of health information. We've given those reports back to them. But their ability, there's other things I'm sure that they want to be able to do with the data. And so to have a regional person or a team that can help them analyze the data, look at it in a different way. They may know better what their community wants, how they want to see it, and it be communicated to them. I do believe would be helpful.
Thank you. Thank you. Hannah. And then to Dr. King following that.
Thank you so much. So Lindsay, my questions were along the vein of Congresswoman Brooks. But I want to make sure that I understand this so that as the commission moves ahead with discussions. So when the Indiana Health Information Exchange was developed, it was developed as a private initiative, private sector initiative. So what we're talking about now is taking an initially private sector strategy initiative and partnering with it and having it support and assist public sector, public health initiatives. So I guess I'm assuming that the states that have like state-based health information exchange, those were driven by and initiated by the public sector. So what are the potential options for partnership, right, moving forward? So are there any examples of states where the Health Information Exchange began as a private initiative. And then that private initiative went through some formalization process to become a public-private partnership. I'm asking this because if we're going to leverage the power of the Health Information Exchange truly for public health, we're talking about including behavioral health groups, right? We're talking about rural providers that may not have funds to start up and report. Our local health departments in no way can pay to access data out of the IHI right now. So I guess I'm asking this, right? Because you're saying there's funding required, but what we're talking about is a private sector strategy solution, and what are the even options to turn that into a public-private partnership that would make it accessible for public health?
Yes, absolutely. So I think you're right. Were the state initiated ones. They were the ones that were really using. That's how they utilize the high tech money. And I will say we also utilize high tech money here in Indiana to help incentivize to get, for example, rural hospitals on electronic medical records and connected to the exchange. So those funds were used here in Indiana as well. But like you said, it kind of in a different way, right? Where we didn't develop the health information exchange from the public side, it was a private entity, and really that money was used to help assist with that connection. There are, private health information exchanges that are, as I mentioned, that are state designated. I think it was Brian Tabor that talked about the four stools, or the full four legs of the stool. 100% public-private partnerships are the future of public health. We have to have the engagement of the private sector in what we're doing with public health. And I would say we have partnered with IHI in the past for public health, and they have been at the table with us, but it has been limited in capacity. And I think the goal of my report here is that there is so much more opportunity here. And I in talking to the leaders of our healthcare, of the big healthcare systems and the hospitals across the state, they also recognize how this data could be utilized for public health, which then in turn helps them better take care of the patients in their community.
Thank you. Dr. King, you're up next.
Yes. So as a founding member for the Indiana Health Information Exchange, and actually there's a group of about 50 physicians who thought processes got together to say, wow, how can we cut our economic healthcare costs? So, you go to a hospital, you got to fill out the same patient information, and you go to another hospital and it's a different patient information, and we just saw all this duplication. But we really hated it when we have a patient that, say, for example, went to Methodist Hospital, had to have an MRI, CT scan, and then next day they're over at St. Vincent being reevaluated, and that they had that MRI, a CT scan, but it's like 2 a.m. You can't get access to it. So, wow, I've got to do these studies. So it originally started for us to say, wow, how can we get access from a clinical standpoint that can really cut down our cost of duplication? But I can look up what someone got treated for a community, know what medicines that they were on, what their allergies that they had. And so it was honestly a remarkable accomplishment. And it was painstaking, but we finally got every hospital system on board. I'm happy to say we've expanded our partnership. Dr. Box is now on our board for Indiana Health Information Exchange, along with me, Brian Tabor from the Indiana Hospital Association. And so we have a number of different people with different perspectives and different disciplines. And you should know that our Indiana Health Information Exchange in these past 10 years got ranked as being in the top 5 health information exchanges in the country. And so that's a huge reputation. We've received some federal dollars for some innovative projects, over $100 million, I think at one time, from a Beacon Hill innovative process. But we definitely recognize how important that public health is in the state of Indiana if we're going to really make some inroads And so our members are definitely more acceptable of trying to do more in the arena of public health. And I'm sure they entertain special projects, but I doubt very seriously they would go from a private entity being taken over by the state as a public health information exchange. They've invested a lot of money, a lot of dollars when there was no money there. And they have certain goals that they do want to accomplish, but they also understand that they are a rich resource and that data can be available to be utilized by the State Department of Health. And we've had numerous meetings discussing, what should that look like? What are things that we can help as an added benefit to the Indiana State Department of Health that would help in some key measures in the state of Indiana? And listen, we're talking to the Michigan Indiana Health Information Exchange people. We've had a long relationship with Cincinnati's collection folks. And so we understand the value of regionalization from a state standpoint in regard to our patients. And so I don't know what more, Brian, you might want to add, because I think you're a little bit newer, but we've had our insurance partners there trying to get, insurance data to see what's available. So, but really trying to help us from a health economic standpoint, but also help us create some needed data that we might need, but we can't always have access for. And could they be of service to the State Department of Health?
Would it be okay, Dr. Moreau, just
Yeah, Brian, please, yes.
So yeah, I mean, and I would say, Dr. Kane is right. I think since I've joined, been involved with IHI, I think, and I certainly can't speak for John Kansky, who's a.
And can I just say one thing before you say something, Brian?
Sure.
John Kansky was our first major director of information technology for our Marion County Public Health Department. So if anybody knows public health, he knows it, understands that data tremendously. I'm sorry, go on.
No, I was going to say, I didn't know that actually, but I was going to say he's a tremendous leader. And I think it is very mission driven. I mean, it is a private entity that was really kind of founded by the health systems, but, Dr. Kane mentioned some collaboration with health insurers and others. So I don't think it really even has to change the structure of the entity to become a public-private partnership, in the way that we think about some other entities that are kind of set up in statute like that. I mean, there may be some benefit to that, but I think it's more just about, IHI works really well. We've heard, some of those comments, but you have these other points of contact that were identified in one of Dr. Weaver's slides where they don't necessarily have the resources to plug into it. And that's where the public sector can come up with is just basically those connection fees, if you will. I think about long-term care, for example. You have some small entities that their information is somewhat limited, the data systems that they use. Many of our long-term care facilities are largely Medicaid. I could see where that's a place now where coming in that we could leverage some of those dollars, get them plugged in. And that really, it helps everybody. It helps us work on readmissions and so many other different aspects. So I don't think we even have to really change the way it's structured. It's just more about looking for maybe some public dollars that could then help those people plug into an already existing system. And I think the strength of IHI has been that it has been, largely sort of private. I think if we look around, and John Kansky could kind of tell you about the history of all the other accomplishments or the history of the other health information exchanges. I think some of them just kind of rolled up and have not succeeded because they were completely public from the outset. And when you had changes in political changes just in the governor's administration. Now it's not as much of a priority, got moved into this agency or that agency, and that's really hampered some. So I think we've got a great foundation, as it's been said, and looking to some of the public funding to get other folks plugged in that just can't today is, I think, a great place for us to, great thing for us to work on.
Yeah, thank you, Brian. I just want to do a time check. It's 2:35, so we have about 25, 30 minutes left before we'll adjourn. We kind of moved right into, I think, we combined questions and discussion. So this has been great because you all have contributed a lot to the discussion. Moving now, Mindy. I think I saw your hand go up.
Yeah, thanks. I wanted to piggyback on what Paul said, and I'm not sure everybody knows the amount of data that local health departments have on the environmental side, and we can't see each other's. So, good examples are food inspections in certain housing or motels or tattoo facilities, swimming pools, bed and breakfasts, all of the things that we're required or do inspect and try to make safer. That data isn't shared. And we have a wealth of it. And, despite a number of attempts, whether it was state databases or whatever, a lot of counties have invested a lot of money. We have a mobile website, so we share all of that so the public can see it. There's the other side of that, is that the public can make thoughtful decisions if they know certain things. And so if we can, always consider all of the medical sharing of data, but also the environmental as well. We have a lot of it, and they're right. A lot of it's still in written form in a good number of the counties, but some isn't. So there would be some that can be populated relatively quickly, as long as it's compatible and doesn't, as Lindsay mentioned, doesn't require a lot of funding from our end. We have it and we keep it because we're required to keep it. So that's something the public wants. That's something we should be able to see each other's counties' information, including disease data, because we really kind of are blocked at our county lines. That is extremely hard. When you're working on an outbreak or an issue, you got to get permissions. And so a lot of that stuff would be great to consider when we're talking about sharing of data, to not leave out environmental, for sure.
Yeah, thanks, Mindy. And I have to say, I was really impressed, Dr. Weaver, with the number of views, for the dashboard for COVID. To the point of how valuable data is to the public and to the constituents, whether it's business or public or what have you. So, Mindy, I think you're really hitting on that too. It's just so important that you have not just the visualization, but the availability of the data. Paul, did I see your hand up once again? And then I think to Dr. Box.
Yeah, I would just say quickly, and this is directly related to the iHigh example, and I think it was terrific conversation, but let me just put it again in the context of looking at the fact that even if everyone was connected, we need the capacity at the state health department, and maybe I'll put this in the form of a question to Dr. Weaver. Even if we had all of this information at the state health department or in our local departments of health, is there anyone that has the capacity, or do we have the analytic capacity to actually look for data trends, to do the analysis of very large data sets, to say, so what is this telling us about the population? And what I guess the point I'm trying to make is that in addition to collecting the data and using it for good and important clinical purposes, part of public health's responsibility is to do the large data set analysis, trend analysis, policy development work. As an example, we did work with our colleagues in Reagan Street and developed looking at social determinants of health. But we used that iHigh data that was so invaluable. We had over 70,000 patients over a 10-year period of time, and discovered some of the trends related to what were the things that were the biggest barriers for patients. That's a huge thing from a public health perspective, because if you can address issues like transportation and food supply and so forth and so on, you can make a huge difference, and that complements the work of our medical care system. But absent that analytic capacity, we would have some real difficulties and challenges. So, Dr. Weaver, do you want to comment about the capacity of the state health department in that particular area?
Yes, and Dr. Box, feel free to jump in here too. So we have limited capacity for that. I mean, you're 100% correct. It is no good to have access to all of this data if you can't do anything with it. Right now, I mean, we have a team for COVID, but we would, in order to be able to best utilize that data, in order to develop, ask the right questions, scrub it to make sure that it is correct and accurate, right? How do you put it in a way that we can understand it, and then a way the public can understand it, a way that it's actionable and can be utilized? Will take investment in a team to be able to do that, right? And we would align that. I mean, we can't boil the ocean. We can't attack every disease or environmental, aspects at the same time. We would have to align that with what the important things that we're going after in the state, or whatever the current outbreak is, and then slowly, continuously build. But no, right now we don't have the infrastructure to be able to do it. And so that is a necessary component. So thank you for pointing that out. I just want to add too about the social determinants of health. I mean, the possibilities here are endless. That health information exchange and down in Cincinnati, if I would be seeing a patient in the emergency department, it'll alert me as a clinician, this person lives in a zip code where there is a high likelihood they do not have access to transportation or to a pharmacy. And so that then therefore can trigger a patient navigator that calls the patient after their visit in the ED and says, can I get you transportation to the pharmacy to pick up your prescription? Right? To make that full loop of care, which I think is really where we should be headed with public health.
Dr. Box. No, we need to hear you.
Mute.
Those are the points I was going to make exactly. And that is that we don't have the personnel to do the analysis all at the state level. Even when we do the analysis and have provided to the local communities and counties their data sometimes in data sets, we get back from a significant number of counties, we don't know what this data means. We don't know what to do with it. We don't know how to analyze it. Can you give us some ideas? So if that data is not presented in a form where it's already been analyzed, where we already can show them trends, where we can already compare them to other counties around them, the rest of the state and other areas, it is not meaningful to them because they don't have the personnel locally. Now, I'm not saying all that. That's probably not true in Allen County. No, it's not true in Marion County, but for a lot of our local health departments. And so what we really need to do is make sure that as we do this, that all of the data that we're collecting, all of the data our local health departments are collecting is presented in a fashion that not only the local public health people, but the elected officials, the not-for-profits, the hospital associations, the healthcare providers themselves, the schools can use that data to understand what's going on in their community and in their surrounding counties.
Thank you. I want to call attention to in the chat. Hannah, do you want to just go ahead and ask your question? I think you and Brian had a little bit in the chat about legislation.
Sure. Thank you for that. So my question, and I'm so sorry, Dr. Weaver, that was kind of couched was, so as a commission, if we see and determine that we think supporting the partnership, right, expansion of the partnership with the IHI is definitely best for Indiana and for public health, what were the options for that? What does that look like? And so that what I put in the chat is, does that require a legislative initiative? Is it simple programmatic and administrative changes from the Department of Health? I guess like operationalizing what you were saying into how we as a commission can create actionable recommendations.
I'll let you answer that, Christina, but I'll give you a perspective from.
Go ahead, Jenny. You go ahead.
I think that when you have a private entity, there may be some concern about something being legislated related to them, and would any control be removed from them that they may not like? Because a lot of times when you go over there to do legislation sometimes, and excuse me, Senator Kinley, you don't always get the same results going in as you thought you would go, and people can sometimes have so different type of perspectives that it can be kind of frightening for folks. And I think they would probably feel it is a lot easier forming partnerships or expanding leaderships without it always being legislated if at all possible.
Are there opportunities for mix though that maintain private sector autonomy and then formalize the public-private sector component? I'm literally just asking because I was sitting listening to your talk, and I will also admit that this is not my area of expertise, but from the systems perspective, I'm wondering, what is that menu of options, right? That
I think you always start out with, honestly, Hannah, you always start out with trying to do partnerships. I mean, if you can do it the simple way, when you start adding a lot of layers, I think it can complicate things and I think it can delay things. So if it at all possible, where you can form relationships or agreements or partnerships without everything always having to be legislated, I think it's a positive thing because I think some things will move a lot faster. It's a lot of flexibility related to that. And so that's just from my experience here in Indiana. We've made more gains, incredible gains, having a lot of flexibility and adaptability where we've been very successful. So it's sometimes it's that unknown quantity that, you know, you don't want someone all of a sudden, they may be mad at the information that we're producing. And so now I'm going to do legislation so you can't release this information anymore. And I say that if you look at what happened with CDC in collecting just trauma data out of CDC, it's unfortunate somebody, Judy, you may remember this, but you couldn't even capture trauma data. You were not allowed to set up a trauma database because of some national legislators was very concerned about that. So I just say, if you're able to do things without trying to legislate everything, that can be beneficial when you're working with a private entity. All right, Christina, you can talk.
Yeah, so Dr. Box and Senator Kenley.
So I was just going to say, I think the important thing is what connections and things do you want to do, and to determine from that how you need to do it. So for instance, a big thing for me when I look at this is if Kentucky's getting 75% of their health information system paid for by Medicaid, what do we got to do that? Because then we can invest our part and get from the federal government what a lot of other states are. I don't know what that requires, but I think you start with where do you want to end up? What do you want here? And then how do you achieve that memorandum of understanding, that partnership, that agreement? And if part of that involves legislation, then it involves legislation.
Senator Kelly.
Yeah, 2 points. First, Dr. Kane, I totally agree with what you're saying there. I've been thinking that throughout this entire thing. If you turn it into a public entity and it's subject to the certain elements of legislation, it's going to be a problem. And so Indiana's actually had more success where we have encouraged public-private partnerships, and we just joined as an entity. And then to Dr. Box's question about the Medicaid reimbursement issue, I think that's low-hanging fruit, probably something we have not paid attention to. There was quite a bit of resistance to the Medicaid program for many years during the time I was in the legislature. In the last few years, we began to wise up a little bit and realize that this is money that's available for problems that you have. And so my guess is that nobody's just really stopped and taken a look at that to see how we could do it. But I do think, going back to the first point, I think any recommendations that we make needs to take Dr. Kane's warnings into consideration, because there is going to have to be a way that we navigate and negotiate that so that we get the benefit of this type of data collection and research without hamstringing ourselves in other ways. So it very, very good discussion on everybody's part, but those are thoughts that I would add.
Yeah, thank you. Mindy, your hand's up. I don't know if that's left up from prior. Did you have any further comments? So we are almost at 2:50, so we're coming down to the last few minutes of our opportunity for discussion. I do want to open up for anyone that's not had a chance to speak or reactions for other commission members. Does anyone have further points or points of discussion? Anything more on rural health? Dr. Veal, any thoughts that you'd like to add?
No, my questions have been answered, I think, for the most part. The only lingering question, which I don't even know if we know this, is who doesn't already partner with iHigh? And I just wonder if there's an opportunity to develop more partnerships, excluding iHigh, from a regional level, for collaboration to tap into the resources that iHigh is already contributing to that local area or that regional area. So, for example, if a local health department isn't receiving the data from iHigh, but the hospital is there an opportunity for collaboration where funding exchange doesn't have to take place and doesn't have to occur? Ideally, they'd be collaborating and working together anyway, which today may not likely be happening. I think I've talked about that a few sessions ago, but that was really the only other kind of outstanding, lingering kind of question that maybe, because I agree, our rural community health departments and some of our rural health clinics are not going to have the funding to support the private sector options, but collaboration certainly could be there. Now, again, you may end up with someone who's paying for the resource and say, well, why am I paying for it, and then contribute. You certainly run into that issue, but that was really from a rural perspective. I thought, well, can't we work together and share it? But I know there's obstacles to that anyway.
Can I answer that?
Yeah, please, Dr. King, jump right in.
So I kind of envision that, you have a lot of local health departments, they don't have that funding. I do pay to be part of this membership, but they're also desperately are trying to, first, we're trying to work on focusing on getting all of our community health center data as part of IHE. And I think that we would look at, like, the Indiana State Department of Health, maybe coming up with a small fee or something like that on behalf of local health departments who don't have the resources to be able to access data. Now, you may not be able to get everything, and maybe there are certain subjects that, wow, I need this information, I can access this information. And it may be that you do it through the partnership with the hospital providing that information to you, or IHE can do it individually. But we were trying to talk about what is it that IHE could provide from a public health standpoint that would be beneficial for everybody from a public health standpoint. What that looks like, I mean, they were just putting up different topics or different subjects, in terms of what that might look like. And we may, as a local health department, may say, what information would I like to see, So I think we have to look at it from our side. What is it we would like to see and be able to access? And what the State Department of Health can't provide, maybe IHE has that information, and so they can be contracted out in order to help provide that information for us. And there's a possibility we could get some federal funds or some prevention funds or some foundation funds that would help, get that particular process started, if it's not in the State Department of Health's budget to help assist in that regard. But I know that IHE wants to be able to do some projects that would not cost local health departments to do, just because it's the right thing to do. They want to work on some public health entities, show that there is value working on certain public health outcomes. But that's a discussion that has to be done with the Department of Health about, where do they need help?
Very good. Dr. Welsh.
Yes, I love this discussion. I maybe want to circle back to a couple of our previous meetings. I think data analytics is a really interesting field, and not everybody's well versed at it. I've been involved with other organizations, and there's a real knack to it, and a real knack of being able to deep dive into the data and get actionable items out of it. So that might be something where we've talked before on our previous meetings about regional resources. So an individual small local health department may not be able to do that, but maybe the region can. The other thing we talked about was educating our local health departments. So people often don't know the right questions to ask. You don't know what you don't know, but people who are able to use the data and make actual items, some people talk about it, best practices. I would like to say best story, how we were able to use the data to help us locally, and then we can push that information out to the local health departments. He's like, oh, so County Jones was able to do that. I wonder if we could do that here. And it doesn't have to be hit over the head with it, but it's education to let you know. And since a lot of local health departments that are successful are tied in with their hospitals, I think this would be a good collaboration with our Indiana Hospital Association, and local health departments working with their hospitals I think do the best jobs. And so I think the hospitals are well versed at looking at data and data analysis, and they may be helpful. I don't want to speak for Mr. Tabor, but I suspect that there's some good information that the hospitals can help us with.
That's a good, we'll toss it to you, Brian.
Okay, great. Good segue there. Yeah, I think one thing, so to sort of answer that question, but also maybe kind of address some, one of Kara's questions and why we do need to identify the sustainable funding is what we need to understand, that it isn't just about taking the data that's already there in the hospitals and from some of our medical providers. We do have a really robust data set here in Indiana, probably more than others. But what we are missing is the input from those other points, right? So it isn't just about giving somebody in the local health department access to the data that already exists. It's, you have to have the staff to be able to train, set up, and support on an ongoing basis all the other data entry points in the system, so that the local health departments, if they're providing care and vaccinations, I guess that's in short, but other services, that data flows back to IHI, and the same with health centers and nursing homes. So it's not, it may seem in the short run like, well, we could just open up the database and have other people have access, but then you're still only looking at what already exists. And we know, especially as we talk about social determinants of health and a lot of the impact being out in the community outside of the four walls of the hospital, that's really where we need to get that data coming in, and to set up all those additional points of entry and to support that on an ongoing basis. That's where we're going to need that public funding support.
Thank you. Dr. Kane, you have the last word.
Just to say that I think as we think about all of this, and I think Brian made a very excellent point, that, you can have one good epidemiologist, a person that can represent a whole region. And it may take two epidemiologists to represent a whole region, depending on the sophistication and how different those two regions are, because someone's got to interpret the data. But I also think that from a health department standpoint, there's got to be someone else on the side of that local health department to help kind of oversee that information. Because now you're not going to pull that nurse over who's providing a lot of services. I can't make that person do that. I can't take my environmental health employee who's looking at septic systems. I can't do that. So even though we need a higher level position as from an epidemiology to help the analytic capabilities of that data, you still will need a data person inside that local health department to help receive that information, know how to disperse it to whoever the respective health department person that's going to be responsible for. So just to say, just an epidemiologist by itself, regional support, is not going to be sufficient. I think we need sort of like a data coordinator or something in each local health department to help look at how that data is dispensed and what activities are associated with it.
Thank you. You know, what I'm hearing, I mean, this has been an exciting discussion today, and thank you all for all your input. I mean, this has been incredibly robust. I'm personally getting really excited about because, and Jenny, you just ended there with really describing the opportunity to create a system that has the components. I go back to Dr. Box's comment about, you know, what's our aim? You know, what is it you're trying to achieve? Then design it, figure out how to mobilize the resources. I heard a lot today that really resonates with our prior discussions, all the way from pipeline going into the high schools and getting folks excited about careers, particularly for today's discussion around analytics and data analytics and opportunities and information technology in the public health sphere. So there's workforce issues, the exemplars that we need to look toward. I know I think we've hit on a few things that we need to do some digging and a little bit more understanding of the Medicaid reimbursement and legislation and those types of things, and then really moving to where we ultimately can go to with our commission's recommendations, by pulling all of this together. So there's a lot to unpack today. So I want to thank you all. I will just remind you that our next meeting will be February 17th, 2022. It'll be from 1 to 3 p.m. We do hope that will be in person. We look forward to getting back in person. And our topic for the next meeting will be adolescent and childhood health. So that'll, again, I think, be an incredibly robust discussion and a lot for us to learn and think about. And so I look forward to that. And with that, I will adjourn the meeting.
Thank you.
Bye, all.
Thanks, everyone.
Bye. See you guys. Be safe.
Bye-bye.
Have a good week.